So we do have robust evidences from statin trials in favor of post-ACS event mitigation that starts within hours to days as a result of inflammation inhibition, and this predates stabilization of plaque by months or years. Now, this benefit is strongly correlated with LDL lowering, as shown again by significant MACE reduction observed in several clinical trials on statins, on PCSK9 inhibitors, and ezetimibe. And the finding is also congruous with significant structural changes in vulnerable plaques in form of increase in fibrous cap thickness, promotion of calcification, and decrease in plaque volume or lipid core burden that transforms the vulnerable to a stable plaque. Now, as for the time of initiation, anti-inflammatory role of statins encourages early initiation. As you can see, statins, through decreasing in isoprenoid synthesis, it cuts down isoprenylation and resulting in inhibition of small G-type proteins, which basically acts as a common base for multiple pro-inflammatory ligands. So a single intervention with statin basically mitigates an exponential phenomenon of inflammation. In fact, if we start statin, the hsCRP levels can be reduced within 24 hours after PCI. And as seen from the graph on the right-hand side, those with high CRP levels, they benefit most in terms of decrease in periprocedural MI with statin therapy. The optimal time, as revealed by a meta-analysis of 15 RCTs, is 1.5 hours before PCI in STEMI and 2 to 25 hours before non-STEMI. The other important point that underscores importance of early initiation is myocyte protection. Statin, through increase in AMP kinase pathway, can lead to myocyte protection and diminution in periprocedural MI. And this is a very important side morbidity post-PCI. As you can see, the CPK elevation, if it becomes 5 times the upper limit of normal, translates into a mortality rate as high as 7.4% at 1 year. And our data from 13 RCTs on more than 3,000 patients demonstrates that in ACS patients, high-dose statin fare much, much better as relates to decrease in periprocedural MI. So these are the few early initiation trials, the ARMIDA ACS and the statin MI, and both of which showed that early initiation of statin do translate into clinical benefit. Now, who to give statins? So we have both American and European guidelines, which identified the patients who will benefit most. European guideline included all the ACS patients. While the American guideline, they have certain criteria, additional criteria, which may be the multiple major ASCVD events or any one of multiple high-risk conditions like age, traditional risk factors, familial hypercholesterolemia, chronic kidney disease, persistently elevated LDL, and history of congestive cardiac failure. Recently, the International Lipid Expert Panel has further modified the European guideline and added extra criteria to identify very high-risk groups. So if you have recurrent MI or any vascular event in last 2 years, and if or you have acute coronary syndrome with multifacial disease or polyvascular disease, familial hypercholesterolemia, and dark diabetes mellitus with at least one additional risk factors like high HSCRP, chronic kidney disease, or high lipoprotein A, you belong to the very high risk group. Now, as for the treatment, what to give? The American guideline recommends high intensity statin, and if the LDL remains more than 70 with the treatment, you can add a non-statin, and you can straight combine PCSK9 with high intensity statin. However, the European guideline favors a more targeted approach. They have set a LDL goal of less than 55, and for those who have recurrent ASCVD within 2 years, it is less than 40, and it is a stepwise increase: statin, ezetimibe, and PCSK9. The latest ILP guideline, however, I think is a more balanced one, where you decide on the therapy depending on the baseline LDL. So if you have both in statin naive and on treatment patients, so if you have an LDL less than 100 or less than 120, you can start with single LLT. The goal is to reduce LDL cholesterol by 50%. If it ranges from 100 to 300 in statin naive and 120 through 300 on treatment, you can initiate with dual LLT, and the goal will be to reduce 50 to 80%. And any patient who has a LDL more than 300, it is recommended to start triple LLT, and the goal should be to reduce LDL cholesterol by more than 80%, and you can follow up every 4 to 6 weeks to up titrate. Now, for the extreme cardiovascular risk group, it is recommended to initiate triple LLT to blunt the short-term recurrent ischemic complication. As we know that more than 20% of ACS survivors can experience a subsequent ischemic event within 24 months. And there you can start straight away with triple LLT, and you have to keep the goal of LDL to less than 40. Now, there is an importance of reloading. If you have a patient on statin who are receiving statin prior to ACS, it has been shown that chronic statin administration can inhibit the reperfusion ischemic salvage pathway, leading to decrease in nitric oxide production, as is shown by the graph below, where the benefit with statin is observed only after reloading the patient with higher dose. And this is what has been demonstrated in Armida recapture trial. Now, should we go for high-intensity statin or LDL-targeted therapy in Indians? Because we know that due to some genetic polymorphism, the plasma level of statins can be doubled in Asians as compared to Caucasians, and similar LDL reduction can be achieved at a lower dose. However, this is an interesting trial from Hong Kong on 8,650 patients, which has shown that the upper curve in red, that is the LDL targeted therapy patients, so they have a higher risk of MACE than the group which is receiving high intensity statin with or even without achieving the target LDL. So this is interesting. Now, there are certain challenges to lipid lowering therapy, and I think we all experience it in our day-to-day practice because of maybe clinical inertia, apprehension about side effect, costs, poor medication adherence, and of course some racial, gender, geographical disparities. Now, the clinical consequences of poor adherence, as shown by this trial, is, I can say, almost disastrous, resulting in an increase in all-cause mortality depending on the percentage of adherence. It can be less than 39% to 80 to 100%. However, there are two interesting information. One, from the US Medicaid, that has shown that high statin persistence after initial discontinuation is more common in those who are reinitiated on a down-titrated dose or on a different statin. And we do have evidence from the Indian patients that we can achieve a lower LDL less than 70, at least with an atorvastatin of 40 milligram. There are several trials, Indian trials. So this is a small paper. It's not a RCT, of course. It's a record-based non-concurrent cohort study from our group on 942 ACS patients, where basically you have seen after giving high dose of statin for 3 months, if you switch over either to atorvastatin 10 or rosuvastatin 10, that gives an adequate protection without increasing cost. However, this fact has to be established by further randomized control trial. Now, the maintenance, the other way to increase adherence is by intervention, and this is a trial that has shown that a direct intervention with the help of nurses can ensure better adherence. So there are some important facts that young male smokers who had their revascularization done and with an eGFR of 30 ml, they are more likely to stick to 80 milligram of rosuvastatin by 1 year. And females, non-diabetics with prior CVD without any statin and initial low or medium dose who are not revascularized and with a less eGFR and high baseline LDL are less likely to stick to high-dose statin. So to conclude, ACS definitely belongs to the high-risk group. The aim of lipid-lowering therapy should be earlier initiation, lower target attainment, and persistence for longer duration. PCSK9 inhibitors are to be used accordingly, especially in Indian setup. The triple LLT should be reserved for extreme severe risk group, and reinitiation at a down-titrated dose or with a different statin may be logical after initial discontinuation. So thank you for your patient hearing.